Okay, everybody can
good-
see Dr. Tralik's.
Good evening, everyone. Again, Beata Tralik. I work for Advanced Fertility Center of Texas, and I am the one who brought the idea of PRP treatment to our clinic. And it's my great pleasure and privilege to share with you, with everyone, our experience we have so far with this very interesting treatment. How did it start? It all started back in 2018 from one very difficult patient. It was a relatively young patient who had good quality frozen embryos, and to our big surprise, when we started preparing her for frozen embryo transfer, patient had very, very thin lining, around maybe 4 millimeters, no more. We tried multiple treatments. We came up with multiple protocols, change route of medication administration, multiple supplements, prayers, whatever we thought about, nothing worked. And by doing some research, we came across platelets PRP therapy as possible option for this patient. So we had great idea, but we had no idea actually how to start and how to separate platelets. But fortunately for us, M-Site came to the rescue. We had M-Site in Houston. We did contact great specialists. They helped us to establish a protocol for this patient. We Dr. Alon flushed the uterine cavity twice with the PRP. How did it go? Not well, I will be honest, didn't work for this patient. And because it was like ad hoc one-time treatment, we kind of kept going with our life until the end of 2019, and we came back to this topic, but this time we tried to establish some type of treatment for bigger group of patients, to establish some type of criteria, protocols, etc. And while thinking about this, we had two patients related to each other, twin sisters, very knowledgeable, who Dr. Alon qualified for donor eggs use. And those two patients didn't accept this option. They declined, which happens very, very often. They wanted to try every possible option to use their own eggs. And they heard about the clinic actually in Chicago that offers PRP. But somehow they found out that we planned to do it. We were not ready yet, not at all, but those two patients qualified themselves for the procedure in our clinic. So we had no choice and we did it. How did it go? Not well. And then COVID came, so everything kind of fell apart. We got discouraged. But then COVID passed, life came back to normal. We said, no, we cannot give up so quickly. We have to keep trying. And our next patient was patient in mid-30s. And actually, Dr. Alon will go over this case in more details. But it was patient in mid-30s with diminished ovarian reserve, failed IVF meaning that she had no frozen embryos. We did PRP, ovarian rejuvenation with PRP on this patient. And to our big surprise and then big happiness, patient got pregnant on her own. So, and this is how it really started. Now, to my knowledge, this webinar is not only for medical professionals. Possibly we have also patients here interested in this type of treatment. So maybe a few words kind of to remind or to explain what actually platelets are. So the platelets are cellular components found in blood that play critical role in the clotting system, and they prevent excessive hemorrhage after injuries. The platelets originate from megakaryocytes, and on the surface, they have molecules that facilitate response to platelets, response of platelets to the injury. Next slide, please. Next slide, please. Now, but what is more interested for us is what is in the cytoplasm of the platelets. We have two types of granules, dense and alpha granules. Alpha granules are the most abundant and they are rich in multiple cytokines and growth factors. I never remember all of them. This is why I have some of them listed here. Next slide, please. And those cytokines and platelets-derived growth factors located in alpha granules play vital roles in many biological processes like cell proliferation, differentiation, angiogenesis, and regulation of apoptosis. And those attributes underscore potential application in assisted reproduction, where they are believed to contribute to tissue repair, wound healing, and blood vessel regeneration. Next slide, please. Now, regenerative therapy in general uses our own body self-repair mechanisms. Now, PRP therapy facilitates organ regeneration through few mechanisms: by exerting anti-inflammatory effects, by orchestrating extracellular matrix remodeling through synthesis of collagen and fibronectin, promoting angiogenesis. Now, the role of VEGF-induced angiogenesis is well documented in normal ovarian function and during the endometrial thickening. So logically, downregulation of VEGF is associated with decreased angiogenesis, leading to reduced development of antral follicles and affects growth of lining in patients. VEGF, by stimulating formation of new small capillaries, improves delivery of oxygen and nutrients to cells. Also, platelets direct cellular recruitment, including mesenchymal stem cells, to the site where they're injected to, promoting differentiation and reparative processes. Next slide, please. Now, what are main indications of PRP use in reproductive medicine? Is poor ovarian response, primary ovarian insufficiency, poor quality or no frozen embryos in previous IVF cycle, thin lining, recurrent implantation failure, Asherman syndrome, and chronic endometritis. Next slide, please. Now, a few words about PRP use in ovarian rejuvenation. PRP has been introduced as the part of ovarian rejuvenation to improve response to ovarian stimulation in patients with poor prognosis. Now, we characterize poor prognosis by factors such as advanced female age, diminished ovarian reserve, underlying female infertility, and response to medications. Next slide, please. Now, there were few both non-randomized and randomized studies published on PRP use for ovarian rejuvenation. I will go over a few, and I will try to do it fast, and I will do my best not to be boring. And I will also kind of explain how it looks like from our perspective. For example, here in 2018, Seals published his research on 4 patients diagnosed with diminished ovarian reserve. All those patients were treated with a PRP. And next slide, please. And then Patrick and Patrick in 2020, very similar, also bigger, a little bit higher amount of patients, 38 patients diagnosed with diminished ovarian reserve, all of them treated with PRP. And what is the conclusion of those 2 studies? According to those authors, the ovarian reserve, AMH, goes up after PRP treatment. Now, for those who are not in medical field, AMH is hormone that shows us if patient has good ovarian reserve, increased or decreased. The lower AMH, the lower ovarian reserve, meaning the less eggs patient has left in her ovaries. Now, I would say that our observation is a little bit different. We have checked AMH multiple times after PRP treatment, and we have not noticed improved ovarian reserve. Although what we have noticed, improved response to medication. So after PRP use, very often we see higher amount of retrieved eggs. Doesn't mean the patient has higher ovarian reserve. It means only that patient responded to stimulation way better. So we were able to retrieve better amount of the eggs, very often better quality, which actually results in higher amount of good quality frozen embryos. Next slide, please. This is the study published in 2022 on 12 patients who underwent IVF treatment and had aneuploid embryos. Aneuploid embryos mean that the embryos were tested genetically and they were not, let's say it's not normal, they were affected genetically. And after PRP treatment, the amount of normal euploid embryos went up from 8% to up almost 40%. So in this and three clinical pregnancies were achieved. So those authors suggest that the PRP can increase the chance that the patients will have genetically normal embryos, which we also would argue a little bit because I want to circle back to better response to medication. Whenever we have higher amount of retrieved eggs and higher amount of frozen embryos, we have better chance to find euploid embryos. Although we had a quite good amount of the patients, especially around 40, a little bit over 40 years old, who had IVF treatment somewhere else in different facilities, and they had no frozen embryos. All embryos were arrested. So they came to us, and after PRP treatment, we were able to freeze very often even good quality embryos, good quality blastocysts. Also, in many of those cases, embryos, especially when we are talking about patients who are 40s or over 40, the embryos were genetically affected. Next slide, please. They have also been published studies with negative results regarding the efficacy of PRP in ovarian rejuvenation. Next slide, please. For example, two of them, one published in 2019, one published in 2022. Here, authors don't see any benefits of PRP use in ovarian rejuvenation, although Stojkowska noticed trend towards higher implantation and live birth rates among patients who received PRP prior to IVF. Next slide, please. Now here, this is the another study published in 2022 on patients with 80 patients with extremely low functional ovarian reserve, aged 28 to 54. And then again, authors didn't see any benefits of PRP use. However, two patients with a very poor prognosis, aged 40, who had previously failed IVF cycles at other centers, achieved pregnancy after PRP treatment. Now, our comment about this research, first of all, patients with extremely low ovarian reserve are very, very difficult group of patients. And if we add patient who is 54, then I would say there is nothing to rejuvenate at this point. So here in this study, I would really question the age group that was selected for this research. At one point, we should stop trying to rejuvenate ovaries. Next slide, please. There were also two randomized trials published in 2024. In those randomized trials, authors also have not noticed any benefits of PRP use in ovarian rejuvenation. Next slide, please. And now, even though those two randomized trials didn't prove that PRP can improve fertility, this field is still exploratory. And after those early non-randomized studies and case series suggested potential benefits, which led to initial enthusiasm. And we at AFCT, we are still very, very enthusiastic, but we all know that this study, this field needs further research on a bigger group of patients with better standardization and optimization of the treatment, what Dr. Farzan highlighted multiple times today. Next slide, please. PRP has been also used multiple times in the patients with thin lining. The increase in endometrial thickness plays very important role in both implantation and in pregnancy. And then endometrial thickness at least 7 millimeters is considered ideal for embryo transfer. Next slide, please. Now, they have been both non-randomized again and randomized studies on PRP use for thin lining. Most studies actually addressing the PRP use on thin lining found positive, good results. For example, here, Chang, 2015, the study on 5 patients between 31, 39 years old. All those patients had thin lining, received treatment with the PRP. In all those patients, lining grew to over 7 millimeters, and all those patients actually got pregnant. Next slide, please. Another research in 2017, here patients with lining 5 millimeters prior to PRP treatment. After PRP, lining grew to over 7 millimeters, and positive pregnancy test was achieved in almost 61%, and clinical pregnancy rate was in 45% of patients. Next slide, please. Now, there have been also randomized trials on PRP use in thin lining, here published in 2018 on 83 patients. And also here authors have noticed very positive effects, beneficial effects of PRP use in thin lining, in patients with thin lining. Next slide, please. Again, 2019, 60 patients. It was double-blind randomized trial, and again, authors have noted very positive effect of PRP use in patients with a thin lining. Next slide, please. In summary, most of studies on the use of PRP to treat thin lining in patients undergoing IVF treatment suggest that this treatment may improve implantation rate. Although in the most recent studies, the authors kind of question the benefits of PRP, which boils down to whatever we already discussed, that this field needs further research on the bigger group of patients with better standardization of optimization, how our own observation looks like in the patients with thin lining. I will be very honest with everyone, we really don't struggle with patients with thin lining for whatever reason. I don't know if we are so good or maybe we are so lucky, I don't know. But yes, the first case that I mentioned in 2018, that unfortunately we were not able to help this patient. The second patient which we had with really thin, truly thin lining, it was the patient, we had her in 2023, 39 years old, poor responder. So it was very difficult to stimulate this patient. Finally, we were able somehow kick her ovaries with the medications. We ended up with one euploid, pretty boy frozen, because the patient was almost 40 years old. We discussed, Dr. Alon discussed with her repeating another IVF round to accumulate more embryos to protect her fertility, her future. Although for the whole treatment, the very tough stimulation was so difficult emotionally and physically and financially for this patient that she decided to move forward with frozen embryo transfer. And to our big surprise, the patient had thin lining. So it was very, very stressful for us because we had only this one tiny boy frozen and thin lining. So again, we went through multiple protocols, changed route of administration of medications, supplements, whatever we could think of, nothing helped. So we moved forward with the PRP, which actually helped. The lining grew to over 7 millimeters. Patient got pregnant and delivered healthy boy. So like I said, and then there was one more patient. Yes, this was not our patient. This patient was referred to us due to thin lining from the clinic in Austin. The lining grew after PRP, after the uterine cavity was flushed with PRP twice. But we did follow up with this patient after the treatment in Austin was completed. Patient got pregnant, but unfortunately had a miscarriage. So like I said, we don't struggle much with thin lining, but what we struggle with, and next slide, please, is recurrent implantation failure. And this is very frustrating topic. It's unsolved problem in assisted reproduction that has led to plateau of our successful rate. It's very, like I said, it's very frustrating for us and it's very frustrating for patients. If we have patients young with good lining, good quality embryos, genetically tested normal, it's sometimes very difficult to understand why a patient is not getting pregnant. Moreover, sometimes those are patients who years earlier got pregnant on their own, and now we struggle. This is very, very complex problem that can arise from different etiologies like advanced age, smoking, body mass index, stress, immunological factors, infection, and uterine pathologies. Next slide, please. There were quite a few non-randomized and randomized studies on PRP use for recurrent implantation failure. Here I listed few of them, 2 published in 2019, 1 published in 2022. Next slide, please. And in most retrospective studies, the authors see lots of benefits of PRP used in patients with recurrent implantation failure. Next slide, please. But there are some other studies during the same period showing contradictory results. Like Dr. Farzaneh mentioned at the very beginning, it's not big surprise because again, and we will be repeating this multiple times, we definitely need further research on bigger group of patients with better optimized and standardized protocols. Also in our clinic, we definitely see big advantage of PRP use in recurrent implantation failure. I would say that the successful rate in this group of patients went up to around 60%. The next slide, please. I am almost done. I am just showing this picture to kind of remind everyone what is our goal. This is our goal. Happy faces of both mom and her baby. So whatever we do, whatever we think of in our clinic, this is our main goal. We want everyone to leave our clinic pregnant and 9 months later to come back with a baby. So we are very, like I said, we are extremely passionate about the PRP use. We are extremely lucky and happy that we came across with MSite and MSite's great specialists. But yes, like I said, we are very, very passionate, but at the same time, we set up very realistic expectations with our patients. Whenever Dr. Alon talks to patients, he really qualifies them carefully. And sometimes we have to say no to our patients. Not everywhere, we don't believe that the PRP is some type of magic treatment that will work for everyone. And unfortunately, this is what patients sometimes think. They will come, they will do PRP, and the PRP that will do its magic. No, it doesn't. And we even have some arguments with patients who are telling us, you know, you have to do it because I will pay you. No. It's not about the payment. It's about us believing that whatever we do will work And whenever we don't believe that the benefits will outweigh the risks, unfortunately, we'll have to refuse. Thank you so much. And Dr. Alon, screen is yours.
Thank you. Thank you, everybody. Being the last speaker is the most difficult part because then I'm trying not to bore you and keep your attention intact. Of course, I'm going to review a few of the things that both Dr. Tralik and Farza reviewed to kind of help you put it all together, hopefully.
Sorry for interruption, Dr. Alon. Would you please share your screen?
You cannot see me, or?
We don't see your presentation.
Oh, can you put it on for me?
Okay, let me try.